You're going to start with your Chris Eubank impression.
This is not the time to do Chris Eubank impersonation.
It's so good. Say 2 Parkies in a pod at the start of Chris Eubank.
Welcome to 2 Parkies in a pod.
It's so good.
When I met him, he was showing me around his Aston Martin, new Aston Martin.
And showing you around it? You make it sound like a house.
He had his new Aston Martin there that he paid a fortune for. And he said, "This hi-fi system cost me £40,000. It has twin tweeters." And then I said, "I like your clothes." He was wearing a monocle and a stick. He said, "These boots are made of alligator skin. They cost me £750. And he spat everywhere.
That is so... How did you keep a straight face?
He'll hit me if I don't.
Oh, right, yeah. And you do have form with boxers, let's face it,
yeah,
right?
Exactly.
Your Mike Tyson incident. Right, let's kick off the show. First one of the new year, right?
2 Parkies in a Pod is powered by Parkinson's UK, the charity that's here to support every Parkinson's journey every step of the way. Wherever you're from, whatever you need, visit parkinsons.org.uk for more information.
Hi there, a very warm welcome. 2026, the first episode of 2 Parkies in a Pod. I'm Dave, he's Kuhn. Together we've had the dreaded Logie for, believe it or not, 28 years now.
28 years. In January, we both had our respective Parkiversaries. What is it for you?
15 years.
I'm 13, so we're in our teenage years with Parkinson's.
Remind people how old you were when you were diagnosed?
38, exactly. 38th birthday, and you were in your 40s,
44.
Young man, right?
Yeah, 44. So I'm 60 this year as well, 2026.
Oh yeah,
I don't look it, do I?
Big one. No, you don't look it at all. You're looking pretty good for 60 and Parkies, well, almost 60 and Parkies, especially in your black polo shirt. You kind of got this Roger Moore look, or is it Roger Moore, or is it James Bond, or the Saint?
I've got this. It's a Polar Explorer's top based on Ernest Shackleton's Antarctic expedition jumper.
Okay,
Lovely. It was a Christmas present. I love it. So
very nice.
He used to wear a jumper like this, sort of loose stitch, keep warm. And he needed it because he got lost, didn't he? And he got stuck in the pack ice, Ernest Shackleton, had to go rescue people.
Well, I'm picturing you getting stuck, taking that polo neck off as well, because that can't be easy, right?
No.
You don't make life easy for yourself, do you, with your clothes?
Exactly. But it's fine. I'll manage it. It might take me a week to get the jumper off, but I'll be fine in the
end. Just in time for the next episode, actually.
Exactly, yeah. A little bird tells me you've been festering a bit.
Yeah. Winter blues we're talking about here, right, Dave? I'm getting up later and later.
It's interesting because I was at yoga class a couple of weeks ago, and the yoga teacher said, "How is everybody out of 10?" People didn't say anything, and then he said, "We'll start at 5." Everyone put their hand up and said 5 out of 10. So I think it's a Parky thing this time of year. Lack of sunshine, bad weather, early, dark nights. It really affects you, and it's affected me as well.
Lack of serotonin. We need all these sort of good chemicals from the sun to help with our mood and movement. So it's not really surprising, but I don't know what we can do about it in the Northern Hemisphere. Maybe we should go down under, Dave. Maybe let's go down under, get a bit of sunshine, and join our good friend, Madam. Let's not call her Madam. Her title is Professor Jane Alty, right?
Yeah, University of Tasmania. We're going to speak to her in a bit about what do my meds do. So I've got some meds that I take that I don't really know what they do, like Rosaglin. I wonder what that does.
We don't have to pronounce it, firstly.
No.
Let them know what it does.
Yeah, exactly. Why are some people on Cinemet, others on Madapar? Why do people take dopamine agonists, all that sort of stuff? We'll find all this out. And when's the right time to start your meds?
When's the right time to start? What do they do? What's a slow release? All these sort of questions that you've kind of had gnawing at you over the years, taking the meds, or if you've just been newly diagnosed, when to start, like you said, side effects and things like that, we are going to cover off in the next hour or so with the great Professor Jane Alty, who's been on the show before last year. We did an episode called Good Day, Good Night, which was about sleep and Parkinson's, but this time it's about medicine, right?
Yeah, she's a really good speaker, really interesting. She's English, but ended up in the University of Tasmania. Story about that is in the last episode. So
exactly. She's from your part of the world, right, Dave?
Yeah, exactly. Yeah.
So
steady. You're not a Yorkshireman.
She's got a Lancashire accent, but she's studying, worked, I think, in Yorkshire, in Leeds, your hometown. And, let's hear from Jane now.
You look great, Q, and I know just before I saw you going in for the op and everything, and it's a big thing, isn't it, to go through? So well done.
Yeah. I remember talking to you, and I was probably still a little bit nervous, I think, as you'd expect, understandably. But yeah, no regrets. So yeah, and I feel good.
Great.
New lease of life and all that.
From my point of view, it's been absolutely amazing. The changing is incredible, absolutely incredible.
Yeah, you look amazing. You really do.
Not a cure, I keep saying to people, but yeah, they're saying it's been life-changing for me. Shall we talk about more conventional treatment by way of medication and sort of? Yeah. We're calling this episode "What do my meds do?"
Professor Jane Alty, welcome back to Two Parkies in a Pod.
Thank you very much for having me.
This episode's called "What do my meds do?" And we're a bit confused about our meds sometimes. A lot of people wonder when it's the right time to start meds, because I remember when I would see my neurologist first time, he sort of handed me a bottle of Cinnamon and said, "Get on with it, you know." Sure, there's got to be a better way than that, hasn't there?
Yeah, good question, Dave. I don't believe that you're confused about your meds either, but I'll answer the question. When is the right time? Great question. I think the right time is really when symptoms of Parkinson's are beginning to interfere with daily activities. So that could be work, it could be walking, it could be handwriting, sleep, and that's going to be a bit different for everybody. But if somebody's saying to me, look, it's really affecting my quality of life, I think that's a good time to be thinking about meds. And I think there has been a little bit of fear in the past about starting meds, and people have this feeling of, I want to save them up. They might, if I don't use them at the beginning, they'll work better later on. And frankly, we know that's just not true, that medications should be given to improve symptoms, and effectively they work throughout the whole disease course. So I often have a conversation with somebody and say, when do you feel is the right time? And if they're saying, I feel, it's affecting my quality of life, that's usually the right time.
I think we could probably close the episode there, Dave, because that was one of our main objectives, right? Just to dispel some of those myths about starting medication. Maybe we'll get onto dyskinesia and motor fluctuations. We'll get a little bit more into that. But I think you just said it so perfectly there, because me and Dave come across so many people in the community that have just been newly diagnosed.
Yeah.
We're even a few years in, right, Dave? And I'm still not taking medication. And to our very unmedical eye, we think that they're suffering, and we're trying to sort of say, don't be afraid to start.
You're so right. And it's a common thing. And I think sometimes when someone's just been diagnosed, they need a period of time to get used to that diagnosis. So actually taking a medication for some people isn't that helpful, in that it's reminding them about the diagnosis. So there can be that sort of psychological effect. But most people, when they take the medication, they say, gosh, I'm glad I feel better. I feel more like my normal self. And I'm glad you used that word, because there are so many myths, aren't there, about medications?
There are.
Particularly about levodopa. And all sorts of things that people believe around levodopa. And I spend a lot of my time exploring those myths and hopefully dispelling them.
Great. So let's talk about levodopa. I mean, what is it?
So levodopa, sometimes also called L-Dopa, is the most established and effective medication for Parkinson's movement symptoms. It does have effects on non-movement symptoms too, but predominantly it's the movement symptoms, the slowness, the stiffness, and the tremor and so on, that it's really helping. And I know I'm telling you things you already know, but Parkinson's, one of the main problems with Parkinson's is that dopamine levels in the brain are too low. So what is levodopa doing? It's effectively topping up those dopamine levels. It's not actually dopamine. It's the what we call the precursor. In other words, it's converted to dopamine in the brain, and that's how it's working. But my goodness, levodopa is such a good and helpful medication.
Yeah.
And without it, we would be lost. It's a very, very effective medication.
The way I describe it, is that without it, I wouldn't be able to talk to you, wouldn't be able to sit here, wouldn't be able to breathe, wouldn't be able to eat, wouldn't be able to sleep, wouldn't be able to function at all, right, Dave? I know it's an old drug, and it has its downsides, and we'll come on to some of those complications rather. But, it's allowed me and Dave, after so many years, to sit here and talk to you. So we're talking about levodopa, but people may not recognize levodopa from the name. So Sinemet, Madapar, Stalevo are all, those are the three main types of levodopa that I'm aware of. And those are the brand names, and then they've each got sort of generic names as well. So it's all a bit confusing, right? If people want to understand what sort of meds they're taking and recognize that is levodopa, those are the main ones, right?
Yeah, that's right. So one of the big clues that you're on levodopa, as well as those names, is that you'll often see a dose, like 100 milligrams, and then a forward slash, and then another dose, 25 milligrams. And
the larger number is typically the levodopa, right?
That's exactly right. Yes, that's right. So people might be thinking, well, what is that smaller number? And that's a great question. That smaller number is what we call a helper medication. It's helping get the most out of levodopa. So the medical name is there's some enzymes called decarboxylase that when you take levodopa, these enzymes break it down gradually. And what is that smaller number? It's an inhibitor. It's putting the brakes on that enzyme so that all the good stuff, all that levodopa can hang around much longer and we get more out of the medication. So the common decarboxylase inhibitors are something called carbidopa. That's in Sinemet. And the other one is bensericide, and that's in Madapar. And in my mind, they both do pretty much the same thing. Yeah. They're both working to put the brakes on the breakdown of levodopa.
So I'm taking Madapar, otherwise known as the other sort of generic name it's known by as co-benodopa. Is that right?
Yes, that's right. Yeah.
And Dave, you're taking...
I'm taking Sinemet, yeah. Why are we on different drugs?
Do you know, in my mind, and I've been managing Parkinson's now for 20 years. This is my opinion now, though. I consider these drugs very interchangeable, the Sinemet and the Madapar. But I have lots of people that come to my clinic and would disagree with that and say, actually, for me, Madapar at exactly the same dose of Sinemet just seems to work better. And, I listen to that because it could be there's a little additive in it or a little extra something. Which is nothing to do with the active ingredient. They've both got levodopa. Yeah. They've both got this enzyme inhibitor. But it could just be the coating on it or something like that suits one person over the other.
I've come across people that have had an adverse reaction to one of them, particularly with nausea, and then they've switched to the other one.
Oh.
But we should say all of this stuff do in consultation with your healthcare team, right? It's not something you should interchange by yourself. But I'm curious. So me and Dave are both taking a form of levodopa.
Yeah.
Now, on a good day, Dave's about 30 kilograms heavier than me. Mainly because he's so much taller.
All muscle.
All muscle, yeah. He's a lean, mean fighting machine, whereas I'm the opposite of that, let's say. But there's quite a contrast in many ways, not least physically. And I wonder, do you take that into account? Because I kind of view taking levodopa particularly a little bit like taking alcohol, right? Dave can have another pint, whereas, little old me, if I have another pint, I'd feel it a lot more. Aren't Parkinson's medications a little bit like that?
I think there's a little bit of truth to that generally people that are bigger might need a bigger dose and people that are a bit smaller might need a smaller dose. But there's also some other factors as well that are quite individual in terms of how quickly you break it down, what stage of Parkinson's you're at and so on. So I tell you my approach. My approach generally is start people on a low dose and go slow. In other words, slowly increase the dose up to the dose that has an effect. Now, we do know roughly most people need to be at the beginning of Parkinson's, let's say between about 300 and 600 milligrams of levodopa in a day. So we know a rough range of what we're aiming for. But there's always people at sort of one end of that bell curve who only need a small dose or they need a much bigger dose. And I think that's a really key part of Parkinson's, that we're trying to optimize the drug regimen for the individual. We don't just hand the same drug out to everybody because it just wouldn't have definitely the same effects with everybody. And in a way, that's also why we don't usually discharge people from the clinic. We say keep coming back because we're trying to tailor that the medication to you as an individual.
That makes sense. Can I ask you, I've heard neurologists in the past talk about a tipping point for things like complications like motor fluctuations and dyskinesia for being somewhere between 400 and 500 milligrams a day. Is that true? Do you subscribe to that? Is that your experience? Or?
To be honest, Kieran, I don't. And I think, again, dyskinesia we know is not just related to the dose of levodopa. It's also related to the amount of dopaminergic neurons that are left and other factors. So, for example, we know women seem to have a higher risk of dyskinesia than men. We're still learning a lot about those sex differences. But as the condition progresses and as there are fewer dopaminergic neurons, you become more prone to dyskinesia at the same dose. So we can't wholly blame levodopa for that. It's also related to the stage of Parkinson's someone's at. And we've got certain ways around that. So, one effective strategy is that instead of giving somebody 3 or 4 doses, where we know they're tending to get quite a high spike and then a drop in the dose, what we can start to do is give slightly smaller doses, but more frequently, let's say 6 times a day. And what we're trying to do there is even out that sort of spike and drop. We're trying to get a more even curve, if you will. What we're aiming for there is something called continuous dopaminergic stimulation, which is what a lot of devices
to smooth things. Yes,
correct. But there are ways that we can tweak the doses, the oral
to an extent. Yeah,
correct. Yes, aiming for more continuous stimulation. Well,
we'll talk about some potential alternative treatments towards the end of this when that becomes less effective. But before we do, what are dopamine agonists, and when would you prescribe an agonist rather than what I would consider to be more like the real thing? Because the way I describe agonists is like a copy drug, isn't it? I'm talking about drugs like Requip, like Pramipexole, like Ropinirole, like Cifrol, drugs like this. When would you prescribe them, or would you prescribe them to your patients? Because there are some known side effects, aren't there?
Yeah, that's right. So we've talked about levodopa, that it's the precursor to dopamine. It's being converted into dopamine, and that's what we want more of in the brain. How dopamine agonists work, they are basically mimicking dopamine. So they're not dopamine, but what they do is they bind on to the brain cells and trigger the same response as dopamine. And you've named a few of them there. They can be taken as oral tablets or as patches, like the rotigotine patch. But they're all working in a similar way to mimic dopamine. Now, when would they be given? Again, a discussion, I always have a discussion with people I see in the clinic about the options. I think dopamine agonists can have a place if somebody wants quite a gentle start to trying Parkinson's medications. They're not really as powerful as levodopa, and so they can have sort of a gentle effect on some of those Parkinson's symptoms. I think they could be quite useful in younger people. But you've mentioned there that there are side effects, and you're right. And some of the side effects that I get concerned about, particularly with older people, is that they can cause a bit of cognitive slowing or a little bit of confusion or sometimes some hallucinations. Now, not everybody by any means, but I think if you're a bit older, you're a bit more prone to those side effects. The thing that we worry about with dopamine agonists is you probably know that many recreational drugs like cocaine and party drugs are also behaving in a similar way to dopamine. And so these dopamine agonists, they can, in about 10% of people, cause some unusual behaviors that we call impulse control disorders. In other words, people can start to binge eat or compulsively shop or have lots of problems with gambling or hypersexuality. In other words, they can't control sort of normal impulses. And it's a side effect of those dopamine agonists. 90% of people who take them, no problem at all. But I think it's something we've become aware of, and we always warn people, and we often warn their other half to say, just keep an eye out for some unusual behaviours, and please let me know if this happens, because we'll either have to take you off them or reduce the dose down.
Do you find patients are open to you about those side effects? Because some of the ones you're reading off could be quite embarrassing. Is there a tendency not to be open with your healthcare team and keep it hidden away until it explodes somehow?
Yeah, I mean, I think sadly that has happened, and probably happened more in the past before we really understood about these potential side effects. That's another reason that I tend to try and have the partner in the room as well, so that there's two pairs of ears listening to this. I think we do know that young men are a bit more prone to these side effects. And we also know that men who may have had sort of impulses in the past, like a tendency to lots of gambling, that would not be an ideal person to put these medications on, because we already
Would
know.
you ask those sorts of questions?
I would.
Yeah,
I absolutely would. To be honest, we have really open discussions in my clinic, and we're talking about all sorts of things that, like the hypersexuality, like the gambling. And I think you just have to be open and neutral about it, really, because ultimately we want the person to be better. We don't want them to have those side effects.
I take the Nupro patch. It works for me very well, but I know a couple of people that got really addicted to gambling because of it. One guy lost a fortune, lost £30,000 gambling.
From the patch?
From the patch, yeah. So you've got to be really careful.
It's an agonist as well, right? Just talking about the patch, Dave, just explain it. So it's about the size of a credit card, would you say? Or
yeah, I've got it on my groin today, so I won't show you. But
I was going to say, give us a demonstration, Dave. No, don't.
Before I have my shower in the morning, I just stick it on, different place every day around my body, and it works really well.
I thought it was upper body that you're meant to have it on, is it not?
Yeah, I think anything from your trunk upwards, yeah.
Anything from your trunk upwards. Is that right, Jane?
It doesn't hugely matter, but we advise people to move it around. Skin, because some people notice that the glue on the patch can be a little bit irritant, and they might get a little bit of redness around where they put the patch on. So we say just move it onto another part rather than keep it for that.
You get a bit of that, don't you, Dave?
Yeah, I do. Yeah, I move it around every day. Probably 10 days on the spin. I won't put it in the same place. So.
I've seen Dave without your top on, and the only way I can describe you and what I imagine your patch experience to be like is: have you seen that movie, The 40-Year-Old Virgin? Where have you not seen it? Where Steve Carell has this waxing session. He's very hairy, and he has this waxing session. It looks very painful, and I imagine you need a clean area, let's say, to put it on, ideally, right?
Yeah. It does give you a free waxing if you put it on a hairy bit.
Right. Okay, but it has its place. Agonists have its place, is my conclusion with this sort of stuff. I say that because it gets quite a bad rep. Quite a bad press.
I agree with you, and I think the pendulum has swung a bit. So I think quite a lot of these dopamine agonists we just talked about came out, let's say, 15 years ago or so. Everybody wanted to use them, and generally we were avoiding levodopa. And then I think some of these side effects and problems emerged. Again, not in everyone, maybe about 10% of people, and then it swung back to levodopa. And I think now we're in quite a nice sort of balanced position where many people would have a low dose of a dopamine agonist and some combination of levodopa. And that's actually got some nice evidence behind it that, when I went to medical school, I was always taught, keep your medications really simple, just keep to one drug. And actually now we're saying probably having a little bit of a dopamine agonist allows you to keep the dose of levodopa a bit lower. And having a combination is not a bad thing for many people.
It's not a bad thing. Talking about combinations, until recently I was taking Entacapone. And Dave, you still take Entacapone, don't you?
Yeah, I take 3 doses of Entacapone a day, just added to the mix. It's when I was going off a bit. So I was having off periods during the day, and it's meant to extend the life of the levodopa, is it? Is that right?
Yes, that's right, Dave. Yeah, so that's a COMT inhibitor. So before I was talking about the dopa decarboxylase inhibitors putting the brakes on the breakdown of levodopa, a COMT inhibitor does something very similar. So it's putting more brakes on it to allow the good stuff, the levodopa, to hang around a bit longer. And Entacapone has some interesting side effects, doesn't it? Where it sort of turns your tears and your urine quite orange or red.
Orange wee.
Yeah.
Lucas said wee. If you're a guy in a pub in one of those communal urinals, troughs, and you're having a pee with Entacapone, you're going to get some strange looks.
Yeah.
But, if that's the worst of it, and when I was on it, and I'm not anymore, but it would extend the life of my Madapar at the time by about an hour. It would get me an extra hour one time. So that's not to be sniffed at, right?
No, you're absolutely right. And then there's a more modern version of Entacapone that's come out, which is a Picapone. You can hear it's got the same ending own. It's in the same drug class, and that can be taken as a once daily tablet.
That's an extended release thing, is it?
Exactly. Yeah. So you should take that instead of Entacapone, not together.
Yeah, right.
But many people as well find that really helpful just to get a longer effect out of each of the levodopa doses, and probably about an hour and a half is typical.
Is that what you're getting, Dave? An extra hour or so?
Yeah, I think so. Yeah, I'm just wondering why I only take 3 a day. I take 5 levodopa a day. Why am I only taking 3 Entacapone?
Hard for me to say that, really, Dave. I mean, you can take more of Entacapone. So I do have people that will take 5 or 6 of Entacapone. So they'll take it with every single dose.
Right.
But it might just be, what your specialist thinks is working best. And again, that idea of keep the number of doses as low as we need it. A bit tricky to say on an individual basis.
The other drug that Dave and I have in common, well, I did take this until recently and I've stopped taking it. I like your view on it. It's a drug called, I'm not sure after all these years if I'm pronouncing it right.
Is it Rezagilin?
Rezagilin, isn't it? I thought it's a J rather than you pronounce it like a J. Is that right?
Yeah, but
Rezagilin.
It's a G. Yeah, you're right though.
Rezagilin.
So again?
Right, okay.
Rezagilin.
Rezagilin.
Great. So now we know how to pronounce it. Thanks. Can you tell us what does it do?
Oh, I thought that was the question. I just had to tell you. So Rezagilin is a monoamine oxidase inhibitor. So again, you're hearing this word inhibitor, which really means something that puts the brakes on the breakdown of the good medications, if you will. So it's slowing down the breakdown of the other medications. There's an older version of it called Selegiline that's been around for absolutely donkey's years, and you can still give it. But Rezagilin is like the new modern version of it. There's only one dose, and you take it once a day at 1 milligram. And really, what is it doing? It's slowing down the natural body's breakdown of all of those good medications and allowing them to last longer and a little bit boost up the effects of them because it's not wearing off as quick. So normally it would be given to people that are saying I'm getting wearing off. My levodopa, instead of lasting for 4 hours, it's now lasting for 2.5. And we would add it in to get a longer effect from each of the tablets.
So you wouldn't take it just by itself?
Not usually. Never
Not
say
usually. Oh, right.
Never say never. I do know some people that have taken it as their very first medication because they want to slow down the natural dopamine reserves. So when we all have dopamine, and people with Parkinson's have a bit less dopamine.
Okay.
So some people will say, I want to take Rezagilin on its own so that my own natural levels of dopamine are effectively boosted up a little bit.
Now, when I originally went on it, that's how it was sold to me. But I think over the years, research has sort of somewhat poo-pooed that, or is that fair to say?
Look, I think, I'm very careful with Parkinson's to say there's one hard and fast rule because I think as humans and as individuals, we have so many differences about us that you will always find a few people say, that worked great for me, that really was a great drug. But on the whole, my experience, and I think the evidence is that really it works best as an add-on drug. But I have had my arm twisted by patients saying, I just want to try that on its own. And, what have we got to lose just from trying it for a few
What have we got
months,
to lose, I stopped taking it about a year ago. And to be honest, I haven't really noticed that much difference. But as we're alluding to in all of this discussion, it's a very individual thing, right?
I'd be reluctant to lose my Resagilin.
Oh,
because,
really?
Because I think my combination of medication is working quite well. I wouldn't want to adjust anything because I'm doing all right. 15 years in, I'm still walking and talking and doing well. So I don't want to lose the med that I've got.
You do get a little bit of, quite a bit of off period in the day. And a little bit of dyskinesia, not so much. What, Jane, can he do for that? I'm thinking about drugs like amantadine. What's your view on amantadine? Because I noticed, I don't know if you saw Professor Baz Bloom recently reviewed a research paper about amantadine in his new Parkinson's Weekly podcast, which is actually quite a good podcast. I've got to say, he's breakdown. Every week he takes a research paper and breaks it down into lay terms. And the last one he did was on amantadine. Maybe we'll leave a link in the show notes for that if you want to go into more depth. But what is amantadine? What's it meant to do?
Yeah, good question. So amantadine is a completely different drug class than anything we've talked about so far. And
used elsewhere as well, right? Originally, it wasn't for Parkinson's.
Yeah, that's right. It was used in all sorts of other conditions before as a sort of antiviral drug, and it was used for fatigue and so on. But you might have heard about this neurotransmitter called glutamate, which is an excitatory neurotransmitter in the brain. So what does that mean? It means it's the go signal to the brain. And in dyskinesia, where people are getting these involuntary extra sort of dance-like movements, there's too much go signal. We don't want to be dancing when we want to be just at rest. So what does amantadine do? It puts the brakes on glutamate. So we've not really talked about glutamate until now. We've been talking about dopamine and precursors to dopamine. Glutamate is a different neurotransmitter. And that's how amantadine seems to be working, that it's stopping some of that excitatory signal. So what do I think about it? Again, I think it's a really individual discussion and choice that I have with my patients about optimizing the medications. I wouldn't use amantadine as a first-line treatment for Parkinson's. We've talked about those, dopamine agonists, levodopa. But it can be really helpful when people are getting either dyskinesia or the other one is dystonia. So when the muscles are contracting and they're getting painful cramps in their feet, or the dyskinesia, the dance-like movements, having a dose of amantadine often can work really well for that. And I would add it in to the other medications.
I'll tell you my experience of amantadine, because when it was first prescribed to me, I was like, oh, what's that for? The neurologist said, oh, that's for your dyskinesia. I said, I don't have dyskinesia. He goes, yes, you do, because he saw it in my hand. My hand was sort of doing these weird movements. It was clawing a bit, and it was sort of stuff that I can recognise in other people, including Dave now. A little bit of it's very difficult once dyskinesia starts, unfortunately, to actually go back, as it were. Amantadine, I took it. I was on it for about 5 or 6 years. As ever, it's very difficult to tell because you don't know what the other side is going to be if you hadn't taken it, right? One of the downsides of it was, in my case, I think it caused a little bit of brain fog. And the way I knew that, and again, I was doing this in consultation with my healthcare teams, I stopped taking it. And I should say I was up to 2 pills a day, and there is only one dose of 200 milligrams. I was taking those twice a day. I think that's the recommended maximum amount.
Yeah, that's a good dose, actually. Yeah.
Is it? Right, yeah. But it was just, I couldn't think straight, and I couldn't multitask particularly, and I was getting not a headache, but I was getting some sort of brain fog, which I'm pretty sure, in my case anyway, was caused
No,
by the amantadine.
I think that's not an uncommon side effect that people would describe. And in a way, it makes sense, because if glutamate is making all your brain cells fire quite quickly, and we're trying to turn that down to stop the dance-like movements, we can also turn down a bit of the firing that we need to be thinking quickly. So it's about getting that fine balance just right. And actually, for that reason, I'm always more cautious with older adults as well, because I think they're more prone to those cognitive side effects. I mean, what I often say to people, though, when we're having this discussion is, we can try it. We can try it. And if you develop these side effects, we can just take you off it. And sometimes that permission just to try it and come off allows someone to feel more control.
Well, I do feel like we should, I don't know, patients should feel a little bit more empowered with this sort of thing, not make it up by themselves, right? But don't be afraid to just try something out, and if it doesn't work, you can stop it in consultation with your. And how would in your clinic, how would that work? Would they call you? I mean, because sometimes the gap between appointments can be quite long, right? So if you're starting a new medication, then you don't have to wait another year before you report back, right?
No, you're absolutely right. So I'm tending to see people about every 6 months, and I also have a team of Parkinson's nurses, which is great. So if somebody goes home, tries what we've planned in the clinic, and it's not worked, or they've got some questions, normally they would phone the Parkinson's nurses, who 9 times out of 10 would just know how to advise. But if they didn't, they can check with me and then advise, and so on. But I tell you, the other thing I've started to do, I've started to write plan A, B, and C, and actually think about that in clinic. So I'll say plan A is, for example, we're going to try amantadine for your dyskinesia. If that doesn't work, plan B would be come off your amantadine and we'll try a slightly lower dose of levodopa.
I like that. Plan B.
Yeah,
I like
and
that.
Plan C, even a plan C cure.
Plan C, yeah.
But people like that, and I think you're absolutely. And I check that with them before they've left the clinic to say, does that sound okay? Are you happy with that? And sometimes they'll say to me, actually, I'd like to try plan C before plan A. And I said, that's fine, but you've got 3 plans there. Because I think you're right, Parkinson's can take away so much control for people. And I think that is control that we can give back as clinicians. Let's come up with a joint plan together. Get
involved, right? Ask the question, report back, have the discussion, but do it. You're an equal, is what I always think, right?
I would say more than an equal, because ultimately it's the person with Parkinson's that decides whether they're going to take what we've even talked about. So they can just completely put the brakes on it and say, I don't like that. And that happens if we don't have a good negotiation in the clinic.
Yeah, and as skilled as and experienced you are, you don't know what the effect is on the patient. And that can only come from them largely, right? I know we do have clinical tests, but they're not, let's say, particularly scientific in a way other than just visual observation, right? So the patient is the guru of this stuff.
I was just going to say, the other thing that I think is immensely helpful is to try and encourage people to learn about their own condition and learn about medications, because then
it's confusing though, Jane. Not all neurologists are like you, Jane, unfortunately. Right, Dave?
Definitely not, no.
Definitely not, right? Yeah, and there is a mentality, and maybe it's an NHS UK specific thing. That whole white coat syndrome, where I'm going to write a prescription, here you go, is very different to the sort of methodology that you've just described there.
I'm really sad to hear that in a way, because I think we as medics are now being taught and trained how to really see the doctor-patient relationship as a partnership, and the old patriarchy of doctor knows best. This is not the way that we're now.
But old habits, I think, Jade. Maybe it's a generational thing. Maybe I'm going to get in all kinds of trouble here. But imagine an older man in your profession, 20 years old, with a bow tie or with a tie of any description, to be honest with you. And but there is that mentality where the example I gave. I'm not naming any individuals here at all, but the example I gave, somebody just prescribing me amantadine without even the discussion. until I asked the question. That's like, surely there's got to be a better approach. For me personally, I prefer this sort of approach where, we have a dialogue about open dialogue, particularly when some of the side effects can be quite complicated and can be quite embarrassing. I think it's even more important to have that open dialogue.
Do you know, I really agree with you, and I could talk all day about the therapeutic relationship, but in other words, that connection you feel with your clinician, do you trust them? Do you like them? Are you on the same page?
It's important. It's important.
It's important. And even when you may disagree with the management plan, can you be open about that? I think if you can get that therapeutic relationship right, it really allows someone to, really live well with Parkinson's, because they can use their clinician as a partner that they're walking along that path with.
I like that, a partner. PRCR-ER-MR-XL. Prolonged release, control release, extended release.
Yeah.
I forget what the M.
Complicated release.
Modified release.
Modified release, yeah. I don't know what the XL. XL is extended life or extended
life. Oh, I don't know. You got me thinking.
I'm testing you.
You're right. All of those 2-letter acronyms effectively mean longer acting versions of whatever the medication is written.
So in most of these medications, including Sinemet, there is an immediate release, which is what I think most people seem to be prescribed. But there are instances where people get prescribed one of these slower release forms, extended release forms. And why would they be prescribed those drugs?
So quite often people would find those quite useful, perhaps for nighttime symptoms.
So before you go to sleep, take an extended release.
Yeah,
because it would last throughout the night, as opposed to something that might wear off after 2 or 3 hours, right?
Yeah, that's the theory. I'm just slightly putting a caveat in there, because we do know that some of those slow release forms of levodopa can be a little bit more erratically absorbed. So again, going back to our point that some people do really well with one med, other people less well. Most people would find if they take a standard dose of Madapar or Sinemet, 9 times out of 10, they can feel that drug working. They know they've taken it out. But some people with the controlled or slow release form of, say, Sinemet or Madapar, they'll take it and then they'll feel like it was almost as if they didn't take it at all. But other people will say, oh, it worked a treat for me. I really got a good night's sleep out of that. So I think, again, it's just about warning people. Let's see how you go. You let me know how you get on with that.
So in my experience, the slow release worked more like a delayed release. Didn't smooth the curve, as it were. What it did, it just held it off, and then it kicked in after maybe 2-3 hours, as opposed to an immediate, which would have kicked in after about half an hour, and it became a little bit unpredictable as well. That was the other thing. So what ended up happening was it was contributing to my dyskinesia rather than helping it, which is one of the things I was hoping it would do.
Yes, that's right. And my experience is that it doesn't work great to try and reduce dyskinesia, partly for the reasons you've just said. I do have some people that take slow release levodopa in the day, but the majority don't. They would tend to use it for an overnight symptom, such as they're waking up at 2 a.m. and they've got terrible tremor or terrible dystonia because they've gone off. And I think there it can work really nicely, actually, to give them a bit better night's sleep.
Can I just ask you where you stand on popping an extra pill now and again, Jane? If you've got going to the gym or doing some exercise or playing current tennis or going to a dinner party you need to be on, is it all right to pop another one occasionally?
Oh, Dave, I think, I'm assuming we're talking about pills of levodopa here.
It's always worth clarifying with Dave.
I thought I better had Ewan, but yes. No, absolutely. And, going back to that negotiation and sort of plan that I have with people before they leave my clinic, I'll often say that to them, and I'll put it on the GP letter. If you feel you need an extra 1 or 2 tablets a day because just as things you just said, you're very active or you've got a big event coming up, you're absolutely fine to do that. The way I tend to do it is to give someone quite a low dose, like just 50 milligrams of Madapar or Sinemet, for example, and then say, if that doesn't quite do what you want it to do, have another one. And I find that's probably a safer way to go than saying, oh, just have an extra 200, because then people can feel lightheaded, they can get dyslexia. So again, that's full of little but often.
My top tip is, even if you're prescribed 100 milligrams of whatever, let's say Cinemet, Madapar, ask for 250s.
Yeah.
Because you've got a better chance of absorbing it, and you've got a better chance of maybe taking one slightly before the other. And that, to that extent, I think there's probably little harm in playing around at that level.
I think that's a great way of doing it. And also, if somebody then says, actually, I'm finding most days I'm needing an extra, 2 of the 50 milligrams, that's telling me it might be time just to increase the dose a bit or add one of these add-on drugs. So it's really good to have that dialogue and update your specialist on how you're getting on.
There's a lot of guilt about taking extra meds, I think. People think they're doing it under the counter sort of thing, and they shouldn't feel like that, should they?
No, they
I
shouldn't.
really don't think so, Dave. And I think it's about having that open dialogue. And don't get me wrong, I've had some patients that really have overdone it. They really are taking way too much dopamine, because there is this thing called dopamine dysregulation syndrome, where people start to feel very happy and get a rush from the tablets. Again, it tends to be younger men that do that. But, if that's happening, it's useful for me to know about that. You normally get a few clues, actually, as a doctor, because they're asking for more and more. But what you're describing, Dave, of saying, I want to take a bit of control back, and I know when I'm going off, and I want something to stop that off, that's a great way of managing Parkinson's. I want my patients to do that. I want them to have a good quality of life. So, yeah, no problem with that at all. And again, I usually put that as part of my management plan. I'll almost do that kind of plus / minus, 2 extra tablets if they need it in the day.
That's good to hear, really good to hear.
That is very good, very reassuring to hear, actually. I think you're right, Dave. That sort of mentality still prevails, right? You feel like an naughty school kid if you pop an extra pill, right? But if you need it, you need it. Can I ask, Jane, what do you think? What do you make of this? 70% of the Levodopa prescribed in the UK now on the NHS is now what they call generic, non-branded versions of the drugs that we've been talking about, particularly Cinemet and Madapar. So people will, instead of getting prescribed Cinemet, they might get prescribed Careldopa, or instead of getting prescribed Madapar, they'll get prescribed Beneldopa. I think I've said that the right way around. And they count for vast majority, 70% now, of the prescribed volume. What do you make of that?
I think giving generic medications ultimately does have the same active ingredients as the branded drugs. And the regulators require evidence of that bioequivalence. So you can't make a generic drug and it be like 50% less powerful. Now, having said that, there will be a degree of error and variation between drugs, and it's a small percentage. But so for the vast majority of people, if they take the generic or if they take the branded, they would say it doesn't matter. However, there are some people that it really matters to them. And they will say that small percentage difference really matters to me. Or there is a slight difference in the absorption because of the way the manufacturer puts different fillers or coatings on that medication. So longish answer, but to most people, I would say it shouldn't make a great deal of difference, but I'm listening. If you feel it does, we'll try and keep you on that same drug. But usually when I've explained that to people, most will say, actually, it was much the same. But not everyone.
Okay. Not everyone, good to know.
They did actually do an interesting study where they put people on, I believe it was Madapar, and then halfway through this study, they switched them to the generic. And then they did, measures of how they were doing and effect of any office change.
There's so much going on when you're living with Parkinson's. It's very difficult to isolate, right? Can I ask, what's your view on Mucuna? Natural levodopa is the way I've had it described.
Yep, that's right. So Mucuna pruriens is coming from flava beans. So it's a natural form, plant-based, of effectively levodopa. And you can get it from health food shops, and you get a little tub and you can spoon it out, and people might put it over their yogurt or just eat it, etc. Look, it's got levodopa in it, so it will work, and it's a precursor to dopamine. And many people will say, I believe in this because it's natural, it's not a chemical that's made into a tablet. My concern with that is that it does not have that dopa decarboxylase inhibitor that we talked about right at the beginning, the helper drug. Do you remember when we talked about the big dose on Madapar and the little dose?
The other bit, yeah.
Exactly. So it doesn't have that little dose bit, which means there's nothing to really stop the breakdown of the good stuff. So it's got the good stuff in it. It's got levodopa, but it's effectively having a shorter effect, and usually will have a few more systemic side effects. So people can say they feel a bit more nauseated on it.
I see.
I think the only sort of caveat to that, or counter argument to that, is that because it's effectively a lower dose, people find they can titrate a lower dose in. So just taking like half a teaspoon here and there. So I think, I say to people, just because it's from the health food shop doesn't mean it doesn't work. Just because it's natural doesn't mean it won't have side effects.
Yeah.
And my general preference would be, say, if you can access the standard tablets, use those. But I'm well aware that in certain parts of the world,
Africa,
people can't get
Asia,
access.
developing countries,
So, it's certainly better than nothing.
Yeah. Well, yeah, I'm also asking because a lot of our American listeners might be interested in this, because I've noticed a trend that they have all starting to get McCuna and rave about it. But I was a little bit, not skeptical, but there's a reason why the levodopa is normally combined with that other component, as it is the case in Cinemet and Madapar. So
a lot of parkies are using CBD as well, aren't they?
Yes. Yeah. Where do you stand on CBD? CBD, I'm getting confused. And actually, maybe where do you stand on CBT as well?
As in cannabis oil.
Yes.
Yeah, do you know, I get asked this a lot, and I don't know, really. I think we haven't seen, unless I've missed something, we haven't really seen the evidence to say this is definitely working. Again, anecdotally, lots of people that come in to see me in my clinic will say, well, it works for my pain or it works for my sleep. And who am I to say it doesn't? So I don't feel I can recommend it because I haven't seen the evidence for that. But I'm listening to what people are telling me, and I'm taking it on board. I think time will tell, really. We probably need randomized controlled trial and see what it's actually good for in Parkinson's.
So we talked about the pills, we've talked about the patch. Now there is another form of Parkinson's medication, not non-oral medication, which we haven't spoken about, which are the pumps.
Yeah.
And the Produodopa pump, we're going to have an episode on shortly. I wonder if you can, well, in the UK it's called Produodopa. I think in the Australia it's called something else. And if you could just explain, sorry, go on.
Yeah, no, of course. So the Duodopa pump is effectively delivering something which is a bit like Cinemet. So it's a levodopa medication, but it's in a gel.
Levodopa, right? Is it?
So that's something slightly different. But yes, these are all levodopa medications.
Okay, liquid.
Yeah, and so the Duodopa, instead of taking it as a tablet, it's through a little tube that goes directly, not actually into the stomach, it's just beyond the stomach, part of the small bowel called the jejunum, where it's absorbed. So most people won't need this. This is quite an advanced therapy because they can get good effects out of their normal medications. But there are some people, for a variety of different reasons, are just not getting that really good on without dyskinesia and so on. And it's another option for those people to consider. It's often being considered at the same time along some of the other advanced therapies like deep brain stimulation surgery, or like an apomorphine pump. Apomorphine's a powerful dopamine agonist. So these are what we call device
rescue drug, right? That one is.
Yeah, that's
Yeah.
right. And, they're great that we have those options, but the vast majority of people won't need them.
So we're talking about medication types are for people that have largely reached not the end of the road with their oral medication, but just something else in the armament that perhaps is designed to sort of manage some of the more complex aspects of Parkinson's, like off periods and dyskinesia and so on. And the reason why the pump and the new Levodopa pump is a subcutaneous thing whereby you can just administer it yourself, right? That's the advantage here. And it seems to be quite effective because it's is it absorbed in the gut then? Is that why it's sort of helping with the absorption and leveling things out a little bit? Or why is it different to taking a tablet form of Levodopa?
Yeah, that's right. So there's a new pump which is effectively a subcutaneous, just under the skin infusion, as opposed to what I've just described, where you need to have a tube put into the stomach, which has been around for, 10, 15 years. That's right. So it's kind of like the new form, which is less invasive. And actually, that hasn't, you guys in the UK got that before we did in Australia. So we're still learning about that. We do have it now, but I feel like the UK experience is much more than ours. So I wouldn't be an expert to talk about that aspect just yet. Give me 6 months.
Can we just briefly cover off DBS? So when would a patient know that they're kind of reaching maybe the end of the road with their oral medication and they should be considering one of these advanced therapies?
Yeah, that's a really important question. Effectively, when the specialist and the patient have been trying a different combination of oral medications or patches or all the things that we've just talked about, and despite that, somebody is not getting good on, or they're only getting on with a lot of dyskinesia. Yeah, that's right.
Yeah.
So it's not that the medications have stopped working. They will always work, but they're causing such an array of side effects that that balance between a good on, the benefit is only coming with a lot of intolerable side effects. And usually that is dyskinesia or rapid switching between being off and on, and just not a good quality of life from those medications. Again, how long do you keep trying with somebody before you get to that point is quite an individual discussion. And what I tend to do is start to introduce the possibility of one of these advanced therapies, such as deep brain stimulation surgery.
Get them to think about it. Get them to
think about it. But we might not need it. It's there.
You might not need it. Yeah.
Because I think often just knowing there's something else reduces some anxiety and gives some control back.
Exactly.
But we will then have a period of time, usually 6 to 12 months, say, of trying other things before we go down that line. But the other thing to say, and I know you know this, but even when you've made that decision to proceed with DBS, it isn't a quick, we'll have it next week. There's months and months of preparing for it. So
2 years in my
case. You don't want to
case.
leave it too late to make that decision. Yeah.
That's what I've done. I've got my name down for it just because I probably need it in 2 years' time. So yeah.
Yeah. So you're going to go through the process, right, Dave? No harm, right?
Exactly.
Yeah.
If I don't think I'm suitable, then it's fine.
Yeah. And if they don't think you're suitable as well, that's
what I'm thinking. Yeah.
Because not everybody qualifies yet.
No.
Yeah, and I've definitely had those discussions, Dave, where I've said to people, look, if you're thinking about it and we might be struggling a bit with meds, go and just start to have the discussions about, one, are you eligible? What does it involve? Find out more about it. Because that's the other thing. Sometimes people go down that line and think, actually, I really don't want it, but it was useful for me to find out about it. And again, it's that common theme. I'm trying to give some control back to people so that they can say in how we manage.
I think what you've explained in the last hour or so is that there are quite a lot of options before you get to that point, right? There are medications that you've talked about that, I wasn't on. There are combinations that you can try. There's a lot in the arsenal, let's say, before you might consider some something like an advanced therapy like DBS.
I really agree with that, Kieran. And I often say that to people, particularly around the point of diagnosis, or even when the going's getting tough and people are
Don't be
getting
disheartened.
to say, do you know, we actually do have a lot of choices here and a lot of different things we can try. And we're not just randomly trying them. We know from big studies, we know from experience what would be a sensible thing to try next. And I think sometimes just giving people that hope and reassurance to say, yes, this is tough, and yes, this is not what we want to be, but there are lots of different things we can try here. And just to say that the vast majority of people that I'm looking after, they actually don't need one of these advanced therapies. So the majority of people are able to live a good life with good management of the Parkinson's and not have an advanced therapy. Now, it's great that we have them, absolutely. And I'm really glad we do. But I think also just giving that perspective to people is useful as well.
Can I ask, how many patients do you actually have on your books, if I can put it like that?
That's a good question. I would say now, because I've taken on a university role, I've probably only got a couple of hundred. But when I was
at the peak.
Oh, I mean, when I was working in Leeds, I think we had about 1,000 patients, but they weren't all mine. We were sharing them between the two.
Yes.
But that was a big neurosciences centre.
Yeah.
We were serving a population of about 1 million. So it's just much more dense population, really. Whereas here in Tasmania, we've got large areas of rurality.
You're not calling people from Leeds dense, are you, Jane?
I know Dave.
He's a proud Yorkshireman. I'm just teasing. Now, if people want to find out more about medication and more about Parkinson's more generally, you've got this wonderful tool called the MOOC. I'm not sure if I'm pronouncing it right, but it's an abbreviation, MOOC, massive open online course.
Yeah, that's exactly right. Thank you, Kieran, for asking about that. And you star on that as well. So people want to see you and not just hear you. They can come.
Don't say that because it'll put people off.
That comes with a public health warning.
Yes, exactly.
Yeah, we were lucky to get some funding actually from two people that had a family connection to Parkinson's over here in Australia, and we effectively developed the MOOC, which is, as you say, massive. That means it's global. Anyone around the world can use it. Open, it's free. And we call it an online course, but I feel course is almost the wrong word because it's not like a course you'd do at school.
Yeah, exactly. Yeah, it's
very interactive, but what is it? Effectively, if you want to learn more about Parkinson's, about the different stages, the different medications, and even just other things we haven't talked about today, but things like exercise and sleep and diet, it's in this course. And what I really love about this course is about half of the people that are educating us, they have Parkinson's. And I think it's that real peer support, real peer education. So you can access it whenever you want.
So it's a website that you can access on your computer, on your mobile. You do have to register. It's completely free. And you work your way through a kind of various, not tutorials, no, I'm saying all the wrong words here. There's lots of interactive content, like you said, that just teach you a little bit about Parkinson's.
Yeah.
Different aspects of it in a very gentle way. Yeah.
That's right. So, for example, we've talked about medications today, and I've talked about dopamine levels being a bit low and medications topping them up. In the MOOC, we show a bathtub with water in it, and we use that analogy where the water level represents the dopamine level. And when you turn on the tap to put more water in, that's the levodopa and the dopamine agonists. And when you put the plug in to stop the water draining out, that's your things like razagiline, your Entacapone, and all these other breaks on the medications. And a lot of people find that visual way of learning just sticks better with them. So we've made it really accessible. But equally, we've got doctors and nurses that have done it, and they've said, I learned loads. So I think it really, people have said to us, whatever you know about Parkinson's, it's given them something. And sometimes that's just connection with other people.
I think you're being a bit modest here, Jane. Just tell us some of the numbers. What's the reach so far?
Well,
it's pretty incredible, right?
Do you know, it really is. So we're up to about 27,000 people have accessed it from 170 countries. Lots of people from the UK, in fact, are on it, as well as have accessed it. But I think the key thing is, Q, and it was really designed by people who have Parkinson's. And they said, this is what I wish I knew when I was first diagnosed. So it's really centered on the person and what they might be going through, and often their other half. So we were really mindful of like the care partner and the families as well.
Where can we find it, Jane?
You just put into Google Parkinson's MOOC, NOOC. You'll see it popping up, and you'll see me popping up a bit and queuing, and I think we'll have to get you on it as well, Dave.
No, nobody wants to see that. Nobody wants to see more of Dave. Maybe Dave could give a live demonstration of you applying your patch and getting a waxing at the same time. No, but what I like about it, Jane, it's very much got your footprints on it, right? It's very much got Jane's DNA. So if you've enjoyed listening to this and Jane's explanation, which Dave and I always think is very, very clear, very, very, you have a wonderful manner about you, then it's more of the same in that sort of language, in that sort of.
We encourage you to scoot to the MOOC.
Very good, Dave. I could see you were trying to cook up a catchphrase in your head. Well done. Excellent. Thanks so much, Jane.
Cheers, Jane. Really good.
Before we close, is there anything else? I think we've covered everything that was on our list. Anything else from you, or anything else that you want to say more generally, even if it's not about medication? Or
well, I think combining, the sorts of principles we've talked about there, where start low, go slow with the increases in medications. I think another key tip is if something isn't working, try not to make a really sudden change. So just make a little tweak down or a tweak up. Again, I think Parkinson's behaves itself a bit better when you do that, when rather than suddenly stopping something or suddenly increasing it. And I'm sure you recognise that yourself. So I think just being gentle with changes is, on the whole, sensible. There's always those exceptions where someone's got a terrible side effect and we've got to suddenly change it. But normally, a little change up or a little change down really helps. But I think my final words would be, and Michelle, who's the co-lead of the MOOC, would kill me if I didn't say it, is that it isn't all about meds. She's a physio. She's someone living with Parkinson's. And, we've also got to remember all those other good things, haven't we? Exercise and sleep and eating well. And I think that combination of the non-medication management along with the medication management really gets the best out of people. So I think those should be my parting words.
Wonderful. You're right. That's a good way to end on. Thank you so much for your time, Jane.
Brilliant.
It's been brilliant.
I love coming on. And even
we love having you on.
I'll talk to him as a Lancashire girl.
Excellent. The question at the start of the show was, what do my meds do? Hopefully we've given you a bit more advice about what exactly they do now, Kuan.
Yeah. It is a bit confusing, isn't it? But I thought she laid it out really quite well, actually. I don't want to say idiot's guide, but certainly a guide for the non-scientific people in the community, the people living with the condition, perhaps their partners as well, to understand what they're meant to do. Just a little bit more awareness. We should probably say with all this, probably should have said from the start, it's a very individual thing, right? As you heard there, seek advice from your own doctor, because people react in different ways to different treatments.
Hopefully it's to leave some fears as well, because people are quite frightened of going onto meds early on.
Again, it's an individual thing, but there's so many people we come across, right, Dave, that newly diagnosed that don't want to start the meds because they fear the side effects, the fluctuations, the dyskinesia. I think you heard that if you're destined for that sort of stuff, you're going to get it anyway, regardless of when you start, particularly Levodopa, right? So just, you've got to make a decision about when it's, how your life is, how your day is today. Don't try and sort of forward plan this stuff too much, right? And do it in consultation with your neurologist or your nurse if they can prescribe as well. But don't be afraid to start and try. What about for 2026, Dave? Do we have any amazing people doing amazing things by any chance to start the
We
year?
have loads of amazing people doing lots of
Come
amazing
on.
things. Are you ready?
Can we hit it?
The
Can we
jingle's
hit the
back.
jingle, please? Jingle.
People with Parkinson's do amazing things.
The wonderful Emma Lawton is self-publishing a new memoir. It's called The Bendy
Yay.
Pencil, a raw, funny adventure about Parkinson's neck chaos, hope, and their quest to lift her head so she can look people in the eye. She's launched a crowdfunder as well to try and generate some money for it and get copies sent out early doors. And you can join that by following the link on our webpage.
Yeah. Emma was one of the first people to talk about her Parkinson's with young onset, right way back in the day.
Similar time to me as well.
Yeah.
About 15
Pink,
years. I
pink
think.
hair. Pink hair is how you recognise Emma, right?
Yeah, lovely.
Distinctive.
And glitter. She always glittery
And
clothes.
glitter. Yeah. Good for her.
You ready again?
Yeah, go for it. Who's next?
People with Parkinson's do amazing things.
From the bendy pencil to a bendy parky.
All
Megan
right.
was diagnosed at the age of 34. I never thought it possible for anyone my age to get this, let alone me. Yoga is very important. I practice, I teach, and generally yoga gives me so much confidence and courage. On the 16th of May, I'll be practicing yoga for 8 hours back to back to help awareness for PD and YOPD.
A yogathon.
We nickname our yoga teacher Bendy Wendy, don't we? Dawn.
Do we?
Maybe we don't do it with you, other people. It's Bendy Megan now.
Bendy Megan, yeah. There's a Just Giving page, I think, for if you want to donate to her yogathon.
Yeah, in the show
Why
notes,
not,
we'll
right?
put that, yeah.
Yeah, I think she's doing it sometime in May, so you got a bit of time. But, show the love, listeners, and give Megan some support.
Okay, you ready?
Yeah, next.
People with Parkinson's do amazing things.
From bendy to bouncy, a grandfather with Parkinson's has survived a 60-metre plunge down a mountain. It took 9 hours to rescue Keith Wilson, who's 74, whose life was only saved because he landed in some soft snow. Incredible.
If it was the same fall and summer, maybe...
Exactly.
Oh,
He actually said, I
no.
honestly thought it was a goner.
Oh,
But
dear.
He survived,
Well,
he's fine.
he survived,
He's writing a book
yeah.
about it as well.
Right, there's a song, isn't there? I Will Survive, Dave.
I'm not singing it.
Yeah, come on, Dave.
Stop trying to tempt me to make an idiot of myself.
Well, I think
It's
you're doing
easy
it
done.
anyway, so might as well add some music to it.
You ready for another one?
Next, yeah, I want to hear more.
People with Parkinson's do amazing things.
I don't know how you pronounce this guy's name. Anders Linus? Lines? Anders Lines?
The Scandinavian guy.
Yeah, a filmmaker
Yeah.
from Norway. Has
Yeah.
made a short documentary called This is Parkinson's 10 Years Later. It shows the progression of Parkinson's a decade after diagnosis. It's a bit of a tough watch, this. I found it quite hard to watch.
It is quite a hard watch, yeah. So he goes back and revisits and interviews people that he originally interviewed a decade ago to see what their progression has been like, and it's quite real, isn't it?
Some people are in a really bad way, yeah, and it's
Really bad way,
it's
yeah.
quite worrying to watch.
It is, yeah.
A lot of smiles and love in there still, you know.
Exactly.
Even though badly affected, they're very,
Yes.
very living life to the full.
Yeah, exactly. And I just love his sort of style of documentary filmmaking, I think you'd call it. And it's worth a watch. We'll leave a link. Any more, Dave?
People with Parkinson's do amazing things.
And finally,
Oh,
fellow
yes. go
Parky
on.
Neil Diamond has become an internet sensation singing karaoke with Hollywood star Hugh Jackman. Jackman is in a film called Song Sung Blue. All about, I know you're going to ask me to sing it in a minute, aren't you? All about Neil Diamond tribute act. The rock star invited Jackman for tea and they ended up getting the karaoke machine out.
Neil Diamond, as in Sweet Carolina.
Yeah. Caroline. Song Sung Blue, everybody knows it.
I thought he retired because of his Parkinson's.
He's still doing karaoke with Hugh Jackman around his house,
Oh, great.
which is why it's so fantastic.
Yeah. Good for him. Good for him.
Totally
Excellent.
amazing.
Amazing. I think that's all we've got time for, isn't it, Dave? We've got to go and yoga and tennis today for what? Busy day,
Yeah,
right?
double whammy, yoga and tennis. We've got yoga at 10,
Yeah.
tennis at
Yeah.
12.
Yeah.
Let's get out there, rip it to pieces.
Now, we start the show with your Chris Eubank impression. I wonder, Dave, if we can close the show with you asking our listeners in the voice of Chris Eubank to like and subscribe to the podcast.
This is Christopher Livingston Eubank. Make sure you like and subscribe our podcast. You'll be fooled to miss it.
Well, there you heard it there.
I'll box
I
your
like the
ears
way
in if
you-
you don't do it.
I like the way you know his middle name. Livingston, is it?
Yeah.
Excellent.
As in
Right.
Dr. David.
Right. Well, that's enough from me, Dave, and Chris Eubank.
We'll get out of
see you
here.
next. We're getting out of here. See you next time.
Bye.
Cheers, bye.
You've been listening to Two Parkies in a Pod, a Parkinson's podcast with Dave and Kuan. To get in touch, visit the website twoparkiesinapod.com or send your voice notes or emails to hello@twoparkiesinapod.com.